Hey everyone, welcome back to my channel, and if you're new here, my name is Mariana Tondo and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is Dr. Michael Post and he's going to talk about Morton's Neuroma. Michael is a physical therapist, diplomate in the McKenzie method, and he published 2 papers about MDT and Morton's Neuroma, a case series and a case report. I hope you enjoy the show.
Hi, Michael. Welcome to PT Pro Talk. How are you today?
Hey, Mariana. Thanks for having me.
Awesome. So let's jump right in. Tell us a little bit about yourself, your background, your career, and how did you get to where you are right now?
Yeah, so without getting too boring with the details, physical therapist, currently treating in Philadelphia, Pennsylvania for a large outpatient hospital system. So I've mostly been in outpatient hospital. I graduated from Ithaca College in 2013, doctorate physical therapy, and took a trip down to New York City, originally kind of small uptown boy in upstate New York, and got a bit of a culture shock there for quite a few years. And he had Laura Mannering on your most recent episode, at least from what I've heard. And her and I both spent time together down at IMC for a year. And that was a great experience, being in the private practice world. And then both my wife and I and our family moved back up to Philadelphia. And so getting back in the hospital outpatient setting, mostly for that kind of academic exposure, and enjoying it so far, post-COVID.
Yeah, absolutely. And it was Laura that recommended me, so I'm very glad she mentioned your name. And then I started looking at your the articles and papers you published and about Morton's Neuroma. So let's talk about that. So what is Morton's Neuroma and how it can be diagnosed medically?
Yeah, Mariana, have you treated anybody with Morton's Neuroma?
I did in the past prior to my McKenzie experience, so I never test with McKenzie to see the results.
Yeah, pre-McKenzie. I've talked to a lot of clinicians, and quite a few have said that they've treated a lot of patients with plantar forefoot pain, not so much that carry the specific medical diagnosis Morton's Neuroma. So you've probably seen some sort of variation or variant of it, or maybe a true Morton's Neuroma that's in there. But Morton's Neuroma essentially is a neuroma or enlargement and irritation of the plantar cutaneous nerves. Thinking a little bit more biomechanically, it's where the medial and lateral plantar cutaneous nerves join in that lateral-ish plantar forefoot. So typically, or most often, between the digits 3 and 4. So essentially, it's a weight-bearing problem. I actually treated a patient today, you caught me a good time, evaluated a patient. My first eval today was a patient referred over from a podiatrist with Morton's Neuroma. And it's probably been, maybe a couple months since I've seen my last one. They still don't come in super often. But patient came in, I kind of cringed a little bit, saying it's kind of one of those like self-limiting diagnoses, kind of like lumped under like plantar fasciitis and that sort of thing. But essentially a weight-bearing, restrictive type enlargement of the sensory cutaneous nerves in the foot. And it will send like burning, lancing, pressure type pains, and sometimes radiating pains into the toes of the foot. Kind of think of it along the lines of like a carpal tunnel syndrome. And eventually, if it progresses and the nerve degrades enough, it'll turn into numbness type sensation of the foot and the toes that they're affected. Okay.
So how is that diagnosed by the doctor? Do they do image exams? How does it work?
Yeah, most often. If you dig into the literature a little bit, there's a clinical practice guidelines for podiatrists that look at as algorithm, and basically, I can't speak for a doctor, of course, or a podiatrist, but receiving the patient, hearing this pain with weight bearing, alleviated with rest, maybe alleviated with massage. Most typically, you'll see a presentation of a middle-aged-ish female is the most common population that we're dealing with here. And probably more due to the restrictive shoes or kind of wearing heels or lifts or any sort of tight toe box. And so some of those symptoms come up in the history there. And there's a few clinical tests that you can use to diagnose Morton's neuroma. I don't know how often they use the whole kind of spattering of tests that are available. You have about maybe 4 or 5 of them that are consistently used. The most popular one being Mulder's click test. So that's kind of the squeezing the toe box or the forefoot and then clicking between or squeezing between the distal metatarsal phalangeal joints at the foot. So most often, if it's severe, if there's a big enough neuroma, you can get a palpable click, just kind of what goes into the name. But most often with a lot of these clinical tests, you're just looking for reproduction of their familiar pain. So after clinical testing, if you send the patient away for MRIs used most often, there's less skill required for accurate diagnosis, and ultrasounds available as well. So largely they're just looking for a cutoff above a certain size. I think it's 5 millimeters of neuroma size is considered clinically significant for an enlarged nerve. And then if that's paired with the clinical presentation, the forefoot pain, then they say, yep, there you go. You've got it. Morton's neuroma.
Great. And then this patient comes to you with this diagnosis of Morton neuroma. So what are the tests that you do, clinical tests and signs that you are looking to assess and diagnosing these conditions?
And hopefully they come to me. It's been a lot of legwork so far, even. I think it's maybe just been 3-4 years now. And I think the most recent count is close to maybe 20 patients or something like that. So not a huge number of patients are really rolling in, even though it's been a lot of reaching out to very specific podiatrists for referrals. But hopefully the patient comes into us, and and the clinical exam is pretty straightforward, pretty typical. Trying to establish patient rapport through history taking, find out my information that confirms. I have like an Epic system that links with the hospital that we work with. So I can get a lot of the basic background information, but mostly just kind of confirming a lot of that information, and then also trying to get and feel out the patient a little bit as far as what their fears are, some of their worries are, their concerns with the rehab, trying to find hopefully strings to pull later on as I'm establishing that therapeutic alliance. And then, once we get through the history, which, most often it's pretty typical, weight bearing type pain. Although you find curveballs and you shouldn't see things like pain with rest, which happens maybe in a really inflamed presentation, or also, if there's that inflammatory component, or if there's also something else going on, as you saw in the paper, as you refer to as a joint derangement that may or may not respond to repeated movements. And then, after getting through that characteristic history, taking a look at the movement exam. So getting a little bit closer to the foot than maybe I would have normally otherwise before starting to see these patients a little bit more often. And looking at toe extension, flexion, range of motion, pretty typical. Maybe you look at strength around the ankle, and then getting into a repeated movements exam, looking at after clinical tests, of course, to establish baselines. But looking at repeated movements exam is kind of the primary component of the examination.
And you do active and then passive, because I bet it's hard to do the active exam.
Yeah, motor control is a little limited, in our feet and our toes. I think that's a good point. I'm a little bit less patient in the extremities, and so I'm jumping to manual pretty quickly. I know, it's McKenzie bias might be, hands off unless necessary, but especially when we're talking to the toes, I'm getting my hands on right away. Yeah, it just kind of lets you and the patient get used to you having your hands on their feet, and getting them used to having their joints moved a little bit, because a lot of times our feet like our hands, we're very protective of them. They mean a lot to us, and something happens to somebody's feet and their whole life is turned upside down. So you don't want anybody guarding during your assessment. So
yeah. And do you use the clinical tests as well that you just mentioned, the squeeze test, the click?
Yeah, so the big ones are, and there's a cluster for anybody who wants to dig through the literature. Owens, and I think it's 2012, talked about this cluster of tests to look at predictive likelihood ratios as far as what the likelihood is of having a true Morton's neuroma, which presents varying degrees of value. If you use the whole cluster, but you've got a squeeze test, you've got a Tunnell's test. There's a digital nerve stretch test that's available, web space tenderness. There's the Mulder's click as well. And there's for differential diagnosis, you might use like a drawer test because you'll find a lot of patients that are referred with plantar forefoot pain. And this is kind of the point of the research is it's hard to differentially diagnose, and you get lots of patients with just joint pain. And so a drawer test is useful because it's not necessarily or traditionally used in the kind of that cluster of Morton's neuroma. And so if you're reproducing familiar symptoms with either, drawer of the toe, or whether it's like compression of the joint with flexion extension or distraction with flexion extension of the joint, the toe joint, then you're thinking maybe not a Morton's neuroma in this case. But a lot of those clinical tests are very, very useful. One for patient education, letting them know that you're there assessing the condition, that they're there for you to look at, and that you're knowledgeable about the condition as well. But then they're also useful baseline test retests. I've had lots of patients that come in with full toe joint range of motion, mobility, and maybe the clinical test is really their only solid baseline.
Yeah. And my next question would be exactly about this differential diagnostic process. So how does this differential diagnostic process of patients with metatarsalgia, oh my God, this word, looks like?
Try metatarsal phalangeal 3 times.
With my accent, then yeah, probably everybody's laughing at me right now. But so how does this process look like? How do you do this rationale of differentiating, and what are the other conditions that are very similar that you can kind of get lost?
Yeah. So, and I try to lay everything out in front of the patient. I've seen a few physicians practice through like some shadowing recently, and I've seen a lot of like shared decision-making process used as far as the patient and clinician interaction. So I've tried to adapt that a lot. And, once you get through the history and the clinical examination, a lot of times, and it goes through, taking just your basic range of motion assessment of the joints, and doing some manual muscle screening, maybe some nerve length testing, and lumbar range of motion screening. I'll just lay it out to the patient in many cases and say, like, look, this is what we're looking at. Here's your odds or your likelihood to have, pain coming from this location, or this is one place that we can start. And, where do you want to start at this point? And just kind of let the patient guide me a little bit as far as where you want to start the clinical examination. So if I'm just using this most recent example, the patient I evaluated today had a history of left SI joint pain, and she had radicular symptoms. She's actually a home health PT. So she kind of had a good awareness of her own body, and, mentioned that, when I'm walking, I also, not only do I have forefoot pain, but I also have left calf tightness. And she knew she had SI joint issues before in the past on the same side. And then she also, during examination, had a positive slump test and a straight leg raise. So I put it right out in front of her and said, like, look, this is what we can look at. We can either, start moving the toes today, and get you moving and try to find out if there's any preference to movement, or we can say, yeah, maybe, and I kind of laid it out to her, like, there is nerve tension here, and you do have a history of back pain, and, this is what we're seeing here. Is it worth testing out for, a few days, whether or not there's any contribution from the back? And she picked back. So that's kind of where we went. And that's part of the differential diagnosis process is like getting patient willingness to participate in a full exam, because that can certainly skew things. And if I jump to, one area of the body or another without kind of getting patient consent from that process, then that can skew the results of the clinical testing pretty quick. Patient can get frustrated, start giving you kind of rash, quick answers about how they're feeling in response to manual interventions or range of motion interventions like repeated movements. And so, try to find the path of least resistance there. So for her, one of the differential diagnoses there is, low back referral. So in that case, I use repeated movements of the spine with or without manual therapy, and look at my baselines for the spine and also for the foot. Also, we're looking at whether it's a joint, just kind of going off of your differential diagnosis there, do we have joint derangement or some sort of directional bias, joint pain that's available? Or we talked about kind of a little bit peripheral nerve entrapment. If you have a true Morton's neuroma, are they getting radicular symptoms because that nerve's actually tight there in and around the plantar surface of the forefoot? If you look at the clinical practice guidelines for podiatry, they also recognize chronic pain or sensitization. We're dealing with some of the clinical baselines are using dolorimeter, or kind of like a pressure algometer. So we're just dealing with like sensitized pressure to the forefoot that has nothing to do with necessarily joint mechanics or movement or lumbar nerve tension or anything from that regard.
Okay. And thinking about the foot, plantar fasciitis, do you see any relation with that, or is that easy to get confused? Or do the patients respond similar when they have their problems when you test?
Yeah, I think that's a good point. Is there sensitivity to your plantar surface? Is that related also to, potentially plantar fasciitis? I've only seen maybe one or two patients that have concomitant symptoms going on, where you end up kind of running into some road bumps during like functional recovery sometimes, or maybe they've had a history of plantar fasciitis before in the past, may or may not have an active episode. Or I've had patients refer to, I don't know if it's any greater frequency than any other patient population, but they're like, oh, my plantar fasciitis, like I've had this issue years ago. And, I feel my plantar fascia pain coming on when I'm, engaging in these functional exercises or something like that. The Achilles ends up being a little bit of an issue sometimes as well. But it all kind of makes sense because you're dealing with kind of a posterior chain type pain. You're also dealing potentially with chronic disability or functional disuse. And if a patient's pain improves and they start changing their functional level or activity, maybe they start walking or doing more in a short period of time, they might start feeling some of these pains in other areas. So
it makes sense. Just take a look at the whole posterior part of your legs and foot to see if they have tension. And what are the signs that would make you think that the pain comes from the back?
The first patient example that I could think of was, pain at rest or pain sitting. We talked earlier, I mentioned and made a comment about kind of that inflammatory component. A lot of patients will attribute to just inflammation or having some sort of itis in their foot just because they feel pain at rest. But if you look at whether or not a patient has a diurnal pattern, maybe their pain's a little bit worse in the morning, gets better throughout the day, which doesn't really make sense for foot pain, especially if you're on your feet a lot, or onset or new onset of pain while sitting. So everybody can aggravate a condition and then sit at rest and take a while to calm down, but can you sit down at rest without pain and then start having pain all of a sudden? And that kind of draws a little bit of some attention to the low back area at that regard. And it's up to you or the clinician at that point if you want to mess around with posture at that point, if they do or don't have symptoms, to see if you can modulate their presentation at that time or kind of use it in that collection. Nerve tension is usually a part of my examination in most examinations, unless contraindicated for whatever reason. And so if there's some sort of ipsilateral asymmetry of nerve tension, then that, potentially is worth exploring depending on how everything else looks.
Yeah, it makes sense.
What do you think, Mariana? Do you go right to the low back after the exam with Richard Rosedale's research and the screen the spine movement, or do you take Scott Herbaui's side here and say, if it's a 50-50 coin flip and, and it's either going to come from the foot or it's going to come from the back, where do you go first?
So I tend usually to clear the spine first. I know it's hard sometimes with the patients because they don't understand or they don't want, but I remember one of my courses I did in Brazil and was with Colin Daves. And then I remember him saying, always clear the spine first. So I kind of got this idea. So even that sometimes I got a patient that he didn't have any back pain, any symptom, anything at all. It was just foot pain. And then I was like, well, let's just clear the spine first because that's kind of my routine. And then his foot pain was gone by just doing the lumbar assessment and doing the repetitive movements. So I kind of tend to always clear the spine first. Unless the patient's super resistant, then I'll do the assessment in the part on the extremity that is the pain, and then try to explain why it's important to clear the spine. So it depends kind of like on if the patient agrees with that, but that's usually what I do. And then I remember I was going to ask you, so in your experience, what is the percentage of patients that you see that have this foot pain or this diagnosis of Morton's neuroma that is coming from the back?
Well, if my current guesstimate is somewhere around and I tell the physicians this too, the podiatrists that I'm working with, if you look at, this is consistent with some of the research related to asymptomatic positives of Morton's neuroma in people's feet, is somewhere around 40%. And that seems to be about the same number of people who respond in a very short period of time or kind of diagnostically appropriate for physical therapy intervention, somewhere between that 35 and 50% range. So if out of that group, those 10 patients with foot pain, if maybe 4 or 5 of them do well with physical therapy, I would say probably 2 of them maybe have some relationship with their low back. Not quite half of the ones that actually respond, somewhere between the 1 or 2.
Yeah, but that's still a big number. It's important to test, right? I think you should.
Depending on next week, what happens with this patient, you may have a different number. I don't know.
Yeah. Yeah. And so let's talk about the study that you published. So derangement syndrome has been classified in a limited number of cases, right? It was I think it was 5 of 13, if I'm not wrong. So if it was not derangement, what would you recommend therapists to do?
Yeah, and that in some cases is the most important question to answer, because if you get the patient better, great. If you mismanage the other patients that are on the table, you're still potentially mismanaging half or more of them in some cases. Some of them are going to be appropriate for injections or back to consult with the podiatrist. That's probably what they wanted to do with the patient in the first place, is inject or a neurolysis or take the nerve out. I find a lot of these patients are sent over because they're particularly adverse to having some sort of advanced procedures done or invasive procedures. So, working with the podiatrist then at that point to say look, if they don't do well in physical therapy, if they're not going to respond, to manual therapies or repeated movements, if they're not a derangement in that regard, or a peripheral nerve entrapment, then they will come back and maybe they'll get some better education to say look, it's worthwhile getting that injection at this point. So that's one part of the population there. In the other part of the population, you're going to have patients with chronic pain or sensitization, allodynia, more or less. And whether or not you have an algometer or a dolorimeter on hand to be able to work through that education process and desensitization process to improve their tolerance. And then there's another population who may not necessarily fit into a clear category and doesn't necessarily respond to repeated movements in one way or another, and just may need more traditional interventions and stretching and mobilizations to the ankle joint to loosen things up and get them used to movement and activity, and alter their pain response. So outside of the derangement and the other category, you've got that dysfunctional category, that peripheral nerve entrapment, that may also get a consult with the podiatrist while they're waiting for their symptoms to calm down, but may need repetitive stretching type activities to loosen adaptively shortened tissues. So
okay. And then I remember looking at the webinar that you did with the McKenzie Institute, that it was manual therapy, I think it was, that was like previously reported in studies, that it was not by physical therapists, but was like manual therapy. I don't know if it was like chiropractors. I don't remember exactly. So how do you feel that these patients respond to like mobilizations, manual therapy, and these type of things?
Yep, and it was chiropractors that initially started that movement, and podiatrists. There's a particular like toe distraction, dorsal glide manipulation that they used for pressure algometry to test and retest to see if they were responders. And so my general experience is they fare well. I'm a little bit biased because, again, as I said earlier, as I kind of go in with hands first in this population, because getting a patient to actively move their joints is somewhat limiting for some regard. In earlier on, maybe I had patients use overpressure initially and kind of hands off, and maybe they do like an unweighted heel raise modification to get that semi-loaded toe extension, or maybe they do a kind of a toes curled push into the floor type modification to get toe flexion as a repeated movement. But again, as it stands, in the whole process, if you want to be efficient and gather as much information through an exam to help the patient out and still get to some valuable time to perform repeated movements in a way, then I'll go hands-on first. So the patient by that point is either appreciating the movements or the activities, or we're getting some answers, or we're sending home with test movements that mimic any of those manual therapies. But as far as using repeated movements with other mobilizations of the foot, I tend not to pair them up too much unless they have, unless they've already shown promise to respond to some other repeated movement. It can be used adjunctively a little bit.
Yeah. So if you test them and they don't respond, you don't find a direction of preference, then you would try to just give exercise to slowly get the tissue used to the movement and all of that, or would you go ahead and try to do some mobilizations, or try both and see what works? What usually is your rationale of the treatment if they don't respond to the repetitive movements?
Yeah, absolutely. And so those repetitive movements would be at the MTP joints, right? Most often as a referred pain. From some of the work that I did with the fellowship training up at Ithaca College, we go a little bit more in depth with some ankle specific mobilizations, or maybe kind of revisiting probably some things that I had forgotten through some of my MDT training process, kind of moved away from that. So kind of moved back in that direction a little bit more, looking at your talar mobilizations, looking at the midfoot inversion, eversion, looking at your cuboid and navicular mobility. One patient in particular that I treated probably about 4 or 5 months ago actually was having her plantar foot pain referred from her cuboid, which was kind of a familiar pain reproduction when I was mobilizing kind of that lateral midfoot. So a lot of that clinical decision making is just made based on their other mobility. So are you looking at the soleus length or the ankle dorsiflexion flexibility relative to what's necessary? There's some good research that looks at leg stiffness, and this is a weight bearing problem, so you'll see runners with this. It looks at leg stiffness predictors and found that ankle dorsiflexion mobility and great toe extension mobility were your greatest predictors for increased leg stiffness when running. So that's my own personal bias, and I'll double check and make sure that the mobility there, the great toe extension, and the ankle dorsiflexion is enough to complete the functional task. So use your own clinical judgment from that perspective. But I definitely try to pair those with functional mobility exercises. And again, trying to look for other forms of a response-based assessment that's not specific to repeated movements of just the metatarsal phalangeal joints. You can still get a patient to walk and mobilize their ankle and, have them retest whatever baseline and, see if there's any change.
Yeah. So I remember reading about functional recovery exercises. So what would you include on that type of treatment? Would you just gradually expose them to exercises and see what they tolerate? So how that program looks like?
Yeah, and it depends on what they're interested in or kind of what level of activity. Are they, amateur athletes? Are they just looking to get back into the gym? Are they office workers? That sort of thing. But most often there's some sort of ambulation restriction, whether it's a return to walking program or an interval return to run program when their symptoms allow it. And then looking at functional exercise that's going to help push the patient confidence, really. Lunges, squats, heel raises, toe walking, heel walking, stair climbing. And then you'll feel out the patient then at that point to find out, where they're having difficulties that you really need to key in on or target in on, from a holistic perspective, to make sure that the patient's rounding out their program and kind of getting their home program to address whatever, remaining limitations on their own.
Yeah, no, that's great, because I think that's the difficult part, because it's easy when we get a derangement, and then if you don't, it's like, well, now what? So just having these options and ideas of what you can use on your treatment is very helpful.
Yeah.
And if you get like a true Morton neuroma that you mentioned before, usually do they respond to repetitive movement, or you find that they don't respond because they are like a true Morton neuroma?
At first I probably thought a little bit like a fish out of water when I was examining these patients and doing repeated movements in the office. So I would say, for sure, don't put it past that you might send the patient away at an exam, not necessarily experiencing a huge change, but usually over a week or so of end range loaded type stretching, you may find a positive response. Classified as a derangement. Again, the numbers are there as far as kind of about that 40 or 50% to see some sort of symptomatic change. Really for that examination, you're looking to kind of target in on just having the right region, making sure that the patient's leaving at the exam, targeting either the back or the foot, with a particular reason. And that gives you the best chance at visit 2 when they come back to have some sort of change. You should either make them better or worse in most cases in an immediate response to the exercise. And you can kind of communicate with the patient on where to go from there, depending on what their response is. I always say that patients is no response is the worst possible outcome. If a patient comes back visit 2 and they're no different, you should find some sort of change, because that at least tells us that we're moving the right area.
Yeah. And so let's say if you have this peripheral neuroentrapayment, if I'm saying this word right. So do you think that you can change that mechanically through our repetitive movements? Like the nerve can be release the pressure of the nerve through these repetitive movements? That's kind of the theory behind. So I'm just trying to get here thinking about the anatomy and the explanation of why the repetitive movements would help if it's really like a neurocompression. So mechanically we are compressing the nerve. Would be that the idea?
Yeah, it's a peripheral nerve entrapment, and then so if that, I tend to think a little bit kind of like a trigger, trigger finger more or less, that nerve through the longitudinal arch at that forefoot is getting compressed from the swelling there, and ultimately it may be the plantar pressure on the at the distal metatarsals that's causing the pain, or one of the other theories as far as what occurs related to the Morton's neuroma is the flexor digitorum tensioning that's created on the nerves through gait or through walking. So are you loosening and kind of stretching, freeing up some of that nerve tension that occurs? And that's probably our mechanistic reasoning as far as what's happening for a patient. Or is there some sort of, maybe there's no change in length, because that's been shown in a lot of other areas of the body that we're not actually changing length all too much, but more of a neurophysiological change in pain threshold. So I'd love to have a study where I get, 50 consecutive patients in the door. So I could at least see all of them. And all I see right now, or all I've seen, are kind of that select few that I'm allowed to see from the podiatrists that are referred over. But thus far, I've only seen, I think, one true peripheral nerve entrapment out of the about 20 that I've seen so far. That patient had a very clean characteristic presentation of, when loaded and when plantar flexing and extending through those toes in a weight-bearing position, he would get a very clean, clear shooting sensation through his toe. And he was a musician who traveled, and he did not want surgery for any reason. So he was willing to go on board with stretching for a few months. And throughout that few months, the pain got less and less. At the end of the day, he ended up still feeling like he was walking on a cotton ball a bit. He still had some pressure between his metatarsal heads. But the same shooting sensation wasn't there. So is that decreased nerve tension potentially? Kind of like doing a, ulnar nerve glide or a median nerve glide or sciatic nerve glide, or so we have more flexibility potentially in a weight bearing or loaded position, or is it just a lack of that, pain firing response? I don't think I know, at least.
Yeah, but you're giving some relief, so that's something, right? Better than having to do something more drastically, some other intervention, surgical intervention or anything like that. So I think that's been super beneficial.
Yeah, the patients, ultimately, if they fail PT, then injections may help, and that saves the nerve. But the other options are neurolysis or resection, and so they take away that part of the nerve, and ultimately they'll lose sensation to half of 2 digits. Again, kind of similar to what you might see with the hand and some of the cutaneous distribution. So ultimately then, I say to patients, look, even if you have a peripheral nerve entrapment and this isn't going to respond in any sort of rapid manner, we're not going to make it worse through the stretching. And it's sometimes worth playing out over at least a few weeks to see if you're going to get any change to the repetitive stretching program, because the other options are take the nerve out and lose sensation. A profound thing I heard related to brachial plexus repair at a surgical conference that I went to see some surgeons talk about different procedures that were kind of up and coming. And they do these amazing things throughout the brachial plexus to repair and return motor function. And the biggest thing that patients often can't get over is just the sensory loss that ends up happening after these nerve type procedures. And so at least a big takeaway out of that from a PT standpoint is just kind of reflecting on the fact that you lose sensation, and it's a really big deal for a lot of people. Losing sensation of a couple toes, that are not your big toe may or may not be important, but at least considering, because patients may not necessarily know about that when they go into a procedure.
Yeah, absolutely. And I'm curious to ask you, what is the most common direction that you see the patients responding to if it's a derangement?
I used to try to make, I think it's split. But I used to try to make rationale after the first few patients that I saw were actually flexion direction. And I was like, oh, it makes perfect sense. You're walking and you're extending your toes, thousands of times a day. So of course, flexion is going to be the reducing common movement for the foot. And then I think maybe the next few I saw were extension based. So I really think it's split. I think there's potentially more variety as far as what you can do. You can do a little bit more weight bearing through an extended toe. So maybe applying a little bit more force and getting better to end range, is available with extension based movements with the foot. Again, I think my articles are open access. You can check those out and kind of look at some of the procedures that are available on PubMed. But I'm going to go 50-50 here. It's got to be fairly symmetrical.
Because you also said like the tension on the flexors. Now I'm just here thinking, if you have tension on the flexors, the extension would make sense because you're kind of like stretching the flexors. So that would be another way to think if it's 50-50, you could say the flexors are tight, or you can say they are walking extension. So flexion would be the movement that they don't do. But yeah,
if they were extension responders, they're doing extension all day, right?
yeah Well, yeah, then they have the flexors are too tight. I don't know why, but great. So that's all very good. Before we go to the final questions here, do you have anything else that you want to share about the study that you did, or anything curious that you found, or anything else that you would like to share?
Yeah, just taking a slow history and gathering more information is always helpful with this population. Before working with patients with Morton's neuroma, and I do tend to see a little bit more feet now, but I didn't see tons and tons of feet. And slowing myself down and taking a different look at the foot and gathering information from various components of the foot is definitely, I would say, helpful, because you'll find the occasional curveball who will have a reproduction of symptoms with midfoot pronation or supination, or you may find out, maybe not relevant to their symptoms, but stiffness that the patient cares about it at the ankle joint that they also want addressed, and it may or may not be related to their symptoms. So we don't see a lot of hands as physical therapists, or at least I don't where I work. And obviously we see a lot of those commonalities between the hand and the foot. And so it kind of took me a little bit of time to slow down through that examination process and make sure that I'm getting all the information rather than just kind of jumping in and just flexing and extending toes without really looking and appreciating some of the movement qualities of the foot.
Yeah. And it was very nice that now you did a study, published a study, so we have at least something to show doctors that we can have some results and hopefully get more referrals, because it looks like they don't refer too much for PTs, right? Because the people have these problems. It's not just that we are not seeing them. So it will be very helpful, as you said, to have more patients to be able to test more and find out more things. So
yeah, Morton's neuroma is the second most common peripheral neuropathy behind carpal tunnel syndrome. So it's up there on the list, and I think podiatrists see that more than most of anything else diagnosis wise. So if you have a contact with a podiatrist and brush shoulders with them a little bit, find out what they think, it helps to sell your timeline to the podiatrist and the communication. That helps too, not just the repeated movements aspect. They want to know how they're going to hear from you as a clinician and what information they're going to get back from you, and that will hopefully kind of help them not kind of keep the patients kind of in their guard, more or less, because again, we're not seeing a lot of them.
Yeah, absolutely. I met one Friday, last Wednesday. So I was just thinking about, I'm going to send these articles and talk to her, see if she would be open to that. But I think that's important. And we have something at least to base ourselves off and show them. So I think that's great. Michael, what is your favorite resource of information? Do you have papers that you like, books, anything that you recommend?
Yeah, I think that's an ever evolving door as far as what I'm looking at, at the current time. Interestingly, over the past few months, because I can borrow books from our medical library, and so I've been reading through some Stuart McGill texts just to find out some more information. I'm not necessarily interested in taking any courses anytime soon, but I just kind of want to peek into the process from that standpoint. So. The Stuart McGill texts were actually really interesting to read through. There's a few things in particular that I appreciated. Namely, he does kind of provocative testing, which I appreciate to find out from a different diagnostic construct. So I thought that was interesting. And then some of the information that he has related to strength and conditioning took me back to my CSCS days and training days to find out a little bit more how he approaches kind of high level athletes. So there's some nuggets of information in there that's really useful.
And what are the name of your studies so people can check it out?
There's two of them. One of them is I think it's MDT and Morton's Neuroma case report. And then the other one is mechanical diagnosis and therapy and Morton's Neuroma case series. Pretty boring bland names. But if you go to PubMed, again, I think they're free access through PMC or something like that. And if you just look up Morton's Neuroma physical therapy post, then it'll come up. There's another PT article that was published in 2016 related to Morton's Neuroma too. That would be kind of the three that are out there. I think those are the only three for physical therapy. And the original one was SAULT in SAULT in 2016. And that actually used more of like a traditional chiropractic manipulation for the toe. So kind of nice to have, a range of information. You could even look up the other case series related to the chiropractic manipulations that are available if you're going to approach your podiatrist.
Yeah. And it's crazy that we don't have that many. I had no idea when I started looking at the topic. And then I found out, I was like, that's crazy. I had no idea. That was so little. And they are free. I looked it up, so I got them so people can just find it online. And what would be advice that you would give to clinicians that are starting their careers?
First and foremost, listen to the patient. I think that's the most important thing. I reflect often back to some graduate training, and one of my mentors was all about mindfulness, and I think that goes in a big way towards listening appropriately to patients and trying to be attentive and focused, and that hopefully helps establish the best connection with the patient as you're going through that treatment process. And I'll throw in 2 words of advice: shared decision-making model. I think it goes a long way as well, trying to help that clinician-patient relationship and guide through that clinical diagnostic process. I know early on as a MDT practitioner, sometimes I was fitting square pegs into round holes and trying to get through examinations that maybe should have been structured otherwise. And slowing myself down and talking to the patient a little bit more and trying to find out, how to meet their needs, I think hopefully helps me capture a few other patients that I definitely lost early on.
Yeah, absolutely. And what personal qualities and abilities that you think are important to become a successful PT?
For me, it's, I guess, intrinsic feedback and critique, always being able to, again, kind of slow yourself down, think about each patient as often as possible, give yourself your own feedback about, what you'd like to do differently, in next time in the same scenario, and try to make small goals to change that. I know we're all caught up in patient care, sometimes burnout or overstretched thin as far as our resources available. But whenever you can, even while you're documenting, just to slow yourself down a little bit and try to think about, how you approached each patient case, and kind of having that intrinsic feedback available is helpful.
Yeah. And Michael, if people want to learn more about you or your work, or reach out to you, is there a way that they can find you?
Yeah, absolutely. LinkedIn, Michael Post, should be on there. And I think that has my email on it as well. Anybody wants to email me, it is michaelpost.penmedicine.upenn.edu.
Great. Michael, I appreciate so much you taking the time to share with us all your experience, and I appreciate all your the papers you publish helping our profession here with a topic that's needs very much some publications and help for these PTs that are trying to treat these patients and hopefully get more referrals. So I really appreciate your work.
Thanks, Mariana.